You're gonna go back to work after this? All right, so we're gonna go down to the threats to pain, rest, and sleep. I did collect them. If you haven't given them back to me, give them back. Whose group are you in? Klein. So just give them to Miss Hawk. Oh, she already left with them. Just wait. Give them to her after and just tell her you're in Klein's group. All right, so these are your objectives for the pain portion. So we're going to talk about acute and chronic pain, the different types of pain, somatic, neuropathic, nociceptive, visceral, examples, how we treat them, talk about adjuvant analgesics, non-pharm pain and symptom interventions, different people and the different responses we have to pain, the need for administration of a PRN pain medicine, and recognizing a client's right in relation to pain management, and then the cultural responses. So we're going to talk about acute pain and chronic pain. So tell me, what's acute pain?
When it lasts only like 3 months?
Yeah, so anything under 3 months is considered acute pain. After 3 months, it's considered chronic pain. But normally, when we talk about acute pain, what is it? Sudden. So it's something, it's secondary to an injury. It's nothing that's kind of like been lingering, right? So it could be from what? Trauma, accident, medical procedures or surgery. It can be anywhere from mild to severe. That's why we ask everybody give me a number on the scale from 1 to 10. It decreases over time. So remember, chronic pain is kind of just like a constant. Acute pain decreases over time. And it's a pretty predictable prognosis. So if I know that I'm having, or that she just had hip surgery, I can say you're going to have, your pain's going to basically follow this progression. You're going to be in acute pain for the first few days, but we're going to manage it with this medication. Once you're up moving around, it should slow. You're still going to have some nerve pain probably for the first year, maybe even, and then you should be good. So, what about chronic pain?
Longer than 6 months.
Longer than 3 months. So it's 3 months, could be years, can be disabling. It can cause anxiety and depression. It's unpredictable as far as the prognosis goes. We use lots of different methods and analgesics. Untreated acute pain can eventually lead to chronic pain. You have one more that has paperwork for clients. So here's our little picture of the classifications of pain. So when we talk about nociceptive pain, that means somatic or visceral. So tell me what somatic pain is.
Localized.
Localized, so like skin or you getting pricked with a pin or something, right? What's visceral pain? Organs. And when we talk about neuropathic pain, it just means that it's stemming from the nervous system, right? So when we talk about the somatic pain or visceral pain, that nociceptive pain, what are some of the ways that people describe pain that's either somatic or visceral? Sharp, throbbing, aching. It can be deep, it can be dull, it can be like a toothache, right? So these all arise from like bone, joint, muscle, skin, connective tissue. Some examples of like a somatic pain would be like a sunburn, right? Examples of a visceral pain would be IBS, appendicitis, pancreatitis. What about neuropathic pain? How do people generally describe neuropathic pain?
Tingling,
burning, shooting, stabbing, tingling, freezing sometimes. Yeah, sometimes they feel like a cold jolt instead of that electric-y. Any of you guys who have pulled your back or anything, like that just little electric-y, like, oh, like it's that sudden, that's like it can be that way, or it can be something where it's been pinched and now like my arm is numb because I have a pinched nerve in my neck, right? So some examples would be like the neuropathy that your patients say that they have, or post-herpetic neuralgia. What about phantom limb pain? So we call that's a type of neuropathic pain. So our different pain assessments that we use. Somebody double check me on the page number 108, table 8.5. Does that seem right?
Yeah.
Okay. I couldn't remember if I updated the 10th edition page numbers in here. There should be like a principles of pain assessment table. What are some important parts of a pain assessment?
Pain,
Quality.
efficient,
PQRST. And when I went to school, we did old cart, but it's basically the same thing. So tell me what PQRST is.
Describe the pain.
Uh-huh.
Quality of the pain.
Right, meaning what? Is it,
rigid,
so the quality means what though?
Sharp.
Dull, sharp, stabbing. So what does it feel like? Any relieving factors. So what makes it better? What makes it worse? Is it radiating? And how long, yeah, onset. How long has it been happening? When did it start? What were you doing when it started? Good. So we always say pain is what? Can I say, oh, what the patient says it is, right? So it's subjective. Pain is always subjective. If they're sitting there, they're playing video games, they're texting their friends and laughing, and you walk in and they tell you their pain is a 10 out of 10, their pain is a 10 out of 10. We want to make sure that we know what the patient's goal is. So you walk into the room, you're giving pain medication, you ask them right now, where's your pain? You go through your PQRST, and you ask, what is your baseline? Like, because a lot of people, especially with chronic pain, they're never not in pain. They're never going to be a 0. So it could be right now I'm giving them pain medicine because they're an 8 out of 10, but their baseline is 4 out of 10. So you need to know what their baseline is, what they're okay with being, because that's what you're trying to get them down to. You're not trying to get them to a 0 because they don't get to a 0. Patients with chronic pain actually become more sensitive to the pain and other stimuli. So a lot of times you're like, you're in pain all the time. Why are you being such a baby? Like, you're used to this pain. It actually gets worse and they get more sensitive. So sometimes it is, you know, you're like 8 out of 10. Sure, you're playing video games, but to them, yes, it's an 8 out of 10. So, let's see. A little bit more on the pain assessment. There's our Baker or Wong-Baker faces, which we almost always use, right? They're on every whiteboard in the hospital.
I think we should use that for everyone.
We do use that for most everyone. So treatment of pain. There's lots of different treatments for pain. So drug therapy, we have non-opiates, which are like your NSAIDs. We have opiates. We have your antidepressants, anti-seizure, and corticosteroids. So when do we use antidepressants, anti-seizure, and corticosteroids? Chronic, what kind? Neuropathic. So we use it for neuropathic pain. That's when you see those patients that are on the gabapentin. Usually they're on it for like neuropathy. They can do therapeutic nerve blocks. They don't last forever. They go in and they actually cauterize the nerve, and they do it under fluoroscopy while you're awake. And from what I hear, it's pretty painful. And but they don't last forever because the nerve grows back, and then they have to repeatedly get them. Physical therapy. So acupuncture. As a nurse, you cannot do acupuncture, right? But your patient, you can refer them for acupuncture. Different exercises, we can give them heat and cold therapy, we can help out with massage, we can give them a TENS unit. Cognitive therapies, so yeah.
Do they actually have 10 units in the hospital?
They have TENS units that, I want to say physical therapy is the one that brings them and gives them to the patient to use. Yeah, and I don't know that every hospital does that, but I know that HCA did. The nursing homes, they probably do too, yeah. Cognitive therapies. So, did you guys, when you were in psych with Miss Morgan, talk about like distraction therapy, hypnosis, imagery, relaxation exercises? Did she have you guys go through any of those and like practice them and stuff? So you can do these with your patients, and you don't need an order. If you're sitting there and you're waiting on the doctor to get back to you for orders for pain medicine, you can try some of these things. You don't need an order for heat or cold or repositioning or distraction. Distraction would just be like talking to you about knowing that you love music, and while I'm waiting, you're in a lot of pain. I just come in and we start talking about music, right? That's distraction. You can do that. Relaxation. So maybe make the room quieter, put on some relaxing music. All the hospitals now, like it's like channel 99 on the TV or something. It's yoga music. And then your adjuvant therapies. So those are going to be the like lidoderm patches. When we talk about different, like if someone's on opiates, and we're going to add adjuvant therapies, that could be when we start talking about adding on like the antidepressants and the anti-seizure drugs and the corticosteroids. What kind of antidepressants do we usually use? SSRIs? What else? The TCAs, so like Elavil and the Norepi. Unfortunately, most of them have side effects that make you pretty drowsy and stuff, but I'm guessing that if we're already on opiates and you're still in pain, at that point you just don't even care. You have to be careful with some of them with the elderly. So when I used to do the orthopedic surgery, everybody came out of a hip, knee, shoulder replacement with the same prescriptions. Everybody was on an opiate, Ativan, and gabapentin. And the first thing I did on day one when I went to go round on them was take them off the Ativan and the gabapentin, because they're already up walking around on those opiates. They don't need that other stuff. It makes them really drowsy, especially the older folks. When we talk about anti-seizure drugs, I mentioned gabapentin. They'll use Lyrica. Local anesthetics like the lidocaine patch, lidoderm patches. And then we use baclofen. You guys know what baclofen is? It's like an antispasmodic. Yeah. So when we, why would we use a mixture of like an opiate and a non-opiate? So give me an example. It is, but also, so like Vicodin, right? So that's what? Hydrocodone and acetaminophen. So we can get a better result without using more opiates.
More of addictive drugs.
And what's that?
Not more.
It is different receptors, but it also, we can use, if we use it along with something like the acetaminophen, we don't have to use as much opiate. So we're decreasing the likelihood of the side effects. It's called the opiate sparing effect, where we can get more pain relief with lower opiates. So not everybody will, fall into this 100%, but this is pretty much the path we take with most people when you have something as far as like the somatic or visceral pain. We always start off obviously with an NSAID. You're not going to come in and say, oh my God, I have horrible cramps, and be like, here's some morphine, right? No, we always want to start off the least that we can do. So maybe NSAIDs or a steroid, and then maybe we'll have to add an opiate. And then we might add, like I was just saying, we have the gabapentin and the Ativan, and we eventually start adding stuff on. And then neuropathic pain, we might use all those same things, but on top of those, we're going to add those adjuvant meds, right? So the anticonvulsants, the antidepressants, the baclofen, and the lidoderm patches. So when we ask you about, and I'm going to repeat this because every semester, you guys get this wrong on the test, and I don't know why. So adjuvant medications that we use along with the opiates and everything else are your anticonvulsants, antidepressants, lidoderm patches. Okay? Side effects. What are some side effects of your pain medications in general? Constipation. What else? Sedation. Respiratory depression. Drowsiness. What about this? Have you guys ever been on like Percocet or something? You get itchy, but you get an itchy nose. I don't know why. So side effects are a major reason for treatment failure or non-adherence, just because people don't like those side effects. So let's say now your patient has been on this for a day and a half, and they call you and they say, this is ridiculous. I can't live for the next 3 weeks through this prescription like this. What are you going to tell them? You could, but they all pretty much have the same side effects. How long are those side effects going to last?
So long as they're taking the drugs.
No, they usually generally go away after about 3 days, except for constipation. So make sure, especially in your elderly population, because remember that thirst goes away, so they're not drinking as much and they get dehydrated really easily, which is going to increase the constipation. So make sure that your patients that are on opiates are on something. And usually at the hospital, they're pretty good about that. You know, every patient gets their Colace every morning, and you know, unless they're on a fluid restriction, make sure they're getting plenty of fluids. So we want to make sure they have a good bowel regimen. What else can we do besides give them fluids and Colace? Exercise. Get them up walking around, right? Everything's going to move more if you're up walking around. What about food? What kind of food can we give them? Fiber, roughage, right?
Increase fluid.
Definitely increase fluids. What else happens with pain medicine? Does it upset your stomach? Nausea and vomiting, right? So we want to make sure that if your patient has nausea and vomiting, that we're not saying, oh, suck it up, Buttercup, because they're either going to start refusing their pain medicine and then we're going to have other issues, or they're just going to be miserable. And then the pain is never going to get better, right? So now they're going to be anxious, and if they're vomiting, especially if it's like they just had surgery somewhere, now that it's causing more pain. So we want to make sure that if your patient even mentions that they're nauseous, you're calling and getting a prescription from that doctor if he hasn't already written one. Hopefully he has, like Zofran or something, just to make sure that we have something in case the nausea gets real bad. What about if you have a 65-year-old patient who has sleep apnea and he's on Percocet after his surgery? What else are you going to want on your MAR for that patient? Oh, well, hopefully he has a CPAP or BiPAP or something. Narcan. Yeah, because it's going to last in their system a lot longer, and if they already have some sort of respiratory something going on, we want to make sure that we can reverse that really quick if we need to.
I was wondering if you could clear up something about tramadol.
I can try.
I've heard a lot of people say that tramadol is not an opiate medication, but it's a controlled substance, and you get tolerance and withdrawal.
Actually, it is derived from opiates, and it actually can cause seizures if you give too much of it. So we were always really careful with that. Usually, like when we stopped after like a total hip or something, when we stopped the Percocet, we'd put them on the tramadol. But we'd be really specific about like no more than this amount every day, because it can cause seizures.
So like the same rules apply with tramadol as with all the other opiates then?
It has less side effects. Yeah. So untreated pain, and I think in level 2, I know when I taught the LPN process, I talked about different things that can happen from untreated pain. But basically, it can really cause problems with your sleep, immunosuppression, psychological dysfunction, because you're getting no sleep, so now you're getting cranky, right? So it's like this kind of like waterfall effect with untreated pain. When you guys are in pain, are you smiling and nice to everybody? No, you start getting a little grumpy, right? And if nobody's fixing your pain and you keep saying, hey, I'm in pain, and now my pain's getting worse, you're getting grumpier and grumpier, and now you're not being able to sleep. So always keep that in mind. Like, I know it's really hard sometimes when you have patients that everybody perceives as your drug-seeking patient, and oh God, he just rings that bell all day. So I have found that the easiest way to deal with those patients is when I get report and they're rolling their eyes and they're like, this guy's gonna kill you because he's gonna be on that bell. If his meds are due at 8, he's calling at 7:30. So the very first time I go into that patient's room during my shift, I bring his pain meds with me as long as he's due within a half an hour. And I say, hey, how are you doing? How's your pain? I have your pain meds. I know they're not due for another half an hour, but I can give them to you now if you want. And then you write up on the board when they're due next. And now you've just become their best friend, and they totally trust that you're going to get them their pain meds when they're due for the rest of the shift. It works. Let's see. So, patient and perception and responses to pain. What are some of the things that people will say when you say, we're going to give you some pain medicine, that maybe is skewed a little, or beliefs that you kind of have to give your patient some education for? They don't want to become addicted. Is that not what all of them say almost? I don't want pain medicine. I don't want pain medicine. I've heard people become really addicted to that stuff, right? So sometimes we have to do a lot of education, and sometimes different cultures have very strong feelings about different types of opiates and addiction. So you have to know what your family goals are and maybe try and work around using certain medications, because we still want to make sure that our patient's getting good pain control. And if they don't want a certain medication, who are we to push that on them? You know, we can explain to them why we think it's the best option or why the doctor thinks it's the best option, but that's always up to the patient. That's that right to refuse at any time. PRN medications we use for breakthrough pain. So these are your patients. When we say it's breakthrough pain, what does that mean?
You give them medication before they feel time they are in pain.
Right, so we've given them medication already. So that's what we're going to consider breakthrough pain, is when we've already treated their pain and they're not due for another maybe 4 hours, and now they're having pain again. And it's not as acute as that first pain usually, because that still is working, but there's a little breakthrough pain. So the cultural responses to pain, again, this is just knowing who your patient is, what their beliefs are. Don't be afraid to ask. Sometimes, like, you'll ask and they'll be like, oh, yeah, and then they'll just pour their hearts out and tell you, and it makes them feel better, too. Again, tomorrow when we get into Ovid, I will pull up the section where it goes through and it shows you exactly, like, how you can get in there and look up a specific culture and their response, like the typical response. All right, so any questions about pain? Where did my pain quiz go that was just sitting here? Oh, I made copies. Hold on, let me get them for you. They're on the printer still. right, so you guys want to go through and answer those, and then we'll go through the answers?
Yes.
Thank you. Oh, it recorded the whole time I was going. I hope you guys didn't say anything bad about me.